Thank you again, Govindan. The nice thing about that ARS is, for me, it can only get better from that point. So I'm going to focus on recent data with switch maintenance therapy and give you the arguments for why switch maintenance approach is preferred. Now, we all can agree that maintenance therapy is evidence-based in non-small cell lung cancer. It extends survival, it extends progression-free survival, but certainly not something we would say every patient should get it. There are clearly factors that are specific to patients, how they responded to first-line therapy, what's the bulk of their disease, how symptomatic they are, what's their comorbid illnesses. All of these factor into our decisions to recommend maintenance therapy for patients. But here are the reasons why we consider maintenance. We know that if you have an advanced stage non-small cell lung cancer patient, no matter how well they respond to first-line therapy, they are going to experience disease progression. And maintenance therapy has the potential to delay progression and improve survival. The other nice thing about maintenance therapy is coming off of 4 cycles of chemo where you've seen some benefit with the chemo, patients are also in a better condition to receive an active therapy as opposed to wait until they progress when they would potentially have more disease and more symptoms, which may limit your ability to give an active agent. And it's also, in the switch setting at least, you're bringing in a drug with a slightly different mechanism of action, so you might be able to get some responses by just bringing in a new agent to something that they have, as opposed to something they have already been exposed to. Now, we can also agree that ideal maintenance therapy agent should be something that's efficacious, that is tolerated well, and you want to be able to give it easily in the outpatient setting and doesn't have cumulative toxicity. And the reason you don't give carboplatin or cisplatin in the maintenance setting is these agents have cumulative toxicity. And affordable, obviously, is a consideration. Now, why would we consider maintenance therapy? There are at least 2 or now 3 phase 3 trials that have shown survival benefit with maintenance therapy in advanced stage non-small cell lung cancer. The argument against maintenance therapy has largely been around the fact that if you don't give maintenance but sit and wait and give an active agent at the time of progression, you see the same kind of survival benefits, which has been supported by the docetaxel immediate versus delayed trial. However, in that trial, when they adopted a wait and watch approach, nearly 40% of the patients never got second-line therapy because of a variety of reasons, one being patient's condition deteriorates so they cannot get an active agent, or they develop brain metastases, so you start focusing on managing their brain disease and so forth. So by giving maintenance, you are able to give an active agent to a greater number of patients. This is the Lilly-Jamin trial that compared pemetrexed to placebo, and this was a switch maintenance trial. Patients got 4 cycles of platinum-based doublet that did not include pemetrexed. And if you look at this trial, they showed a clear improvement in PFS and overall survival favoring pemetrexed. And the tolerability of pemetrexed is something that lends itself to being able to give this drug over an extended period of time. The hazard ratio here in non-squamous histology was 0.44 for PFS, and the median overall survival was improved by nearly 5 months in the non-squamous group. Here is the overall survival hazard ratio was 0.7. The second agent that's approved in maintenance therapy setting is erlotinib, and this was also tested in the switch maintenance setting. So patients with advanced stage non-small cell lung cancer received 4 cycles of a platinum-based doublet, and then those who have stable disease or better were randomized to erlotinib or placebo. Now, this trial did not select patients based on EGFR status in the tumor, but certainly that's something that came out of this trial that was very interesting. Here you look at the PFS in EGFR mutated tumors, there's a hazard ratio of 0.1, and nobody would argue that these are robust results, that if a patient with EGFR mutation should get erlotinib if they did not get it in the frontline setting in the maintenance setting. This is the PFS for the overall patient population, regardless of EGFR status, and you see a hazard ratio of 0.7 favoring the use of erlotinib. If you look at the overall survival in the trial, once again, across all patient groups, there was a modest improvement in overall survival. The hazard ratio was 0.8, favoring the use of erlotinib to placebo. And interestingly, when you look at the survival by EGFR status, it's the wild-type patients where the survival difference was seen. In the mutated patients, there was no statistically significant improvement in overall survival. And obviously, one could attribute that to post-progression therapy in the control arm, since patients, majority of them ended up getting erlotinib at the time of disease progression. So what about continuation maintenance? I know Jerry is going to talk about the Paramount trial, which showed that continuing pemetrexed beyond progression was associated with improved survival that was reported last year. In 4599, Dr. Sandler's regimen, somebody referred to bevacizumab as Sandler's statin at some point. It was carboplatin, paclitaxel, and bevacizumab. It was continued maintenance with bevacizumab, and that was the strategy that led to improvement in survival. So for a patient who gets carboplatin, paclitaxel, and bev, continuing bevacizumab has been adopted, though the value of bevacizumab in that continuation or the maintenance setting has not directly been compared to no maintenance or some of the other standard agents. In the FLEX trial that involves cetuximab with chemotherapy, once again, for patients who had stable disease or better, cetuximab was continued as maintenance therapy. And there we saw a modest improvement in overall survival favoring the three-drug combination. Once again, the value of cetuximab in that maintenance setting was not something that the study was designed to address. So about a year and a half ago, our group did a meta-analysis of all trials that used single-agent maintenance therapy, and this was published in March 2012. And here you see a variety of studies. The only study that was not included in this among the relevant maintenance trials are the Paramount trial and the most recently published AVAPOL trial, but there it was double-agent maintenance, not single-agent maintenance. So if you look at it overall, there was a favorable effect with maintenance therapy. Hazard ratio was 0.86. And then we looked at switch maintenance trials among all of these trials, and the hazard ratio was 0.84, and the differences were statistically significant. When we looked at continuation maintenance, here the hazard ratio dropped to 0.92, and the confidence intervals were wide, so it was no longer statistically significant. Now, the last point I want to make is these are the most authoritative guidelines that we have. These are systematic, evidence-based, comprehensive review of literature. And the first author here is Dr. Jerry Azzoli, who is going to be the speaker next. So let's see what he said just in 2011 about the role of maintenance therapy in lung cancer. Okay, if you can't read it, I'm going to read it for you. For those with stable disease or response after 4 cycles, immediate treatment with an alternative single-agent chemotherapy, such as pemetrexed in patients with non-squamous, docetaxel in unselected patients, or erlotinib in unselected patients may be considered. He did not say use continuation maintenance therapy. He said alternative agent. So I think that makes my case more than anything else I've said, based on what he said. So my conclusions are switch maintenance therapy has a clear survival advantage. If you look at continuation maintenance, it has only been proven with pemetrexed, and it cannot be recommended as a generic strategy. And finally, the ongoing maintenance trial that will hopefully address some of the important issues that we've been trying to find answers for is the ECOG 5508, where patients get 4 cycles of carboplatin, paclitaxel, and bev, and those with stable disease or better are randomized to either bevacizumab, pemetrexed, or both. And this trial has an estimated sample size of approximately 1,300 patients, and it's well past the halfway point by now. So thank you very much for your attention.
Thanks, Ram.